Good evening, everyone. This session is a symposium on vasodilatory beta blockers in clinical practice. The 1 hour session, which will be moderated by Professor Mancia. Can I request you, sir, to come to the dais? Professor Mancia is the Emeritus Professor of Medicine, University of Milano, President, European Society of Hypertension Foundation, ESH Educational Board, Chairperson, ESH 2023 Guidelines. Many of you in this audience probably are aware about the guidelines which were published in the year 2023 by the European Society of Hypertension. He is the principal investigator and person who was involved in coming out with the guidelines of 2023. We are really very, very happy to have you here with us this evening to participate. The speakers, about 4 speakers are here. I think I can request Dr. Mancia to introduce the 4 speakers. Then we'll probably take the questions at the end, please.
Thank you very much for the introduction. Ladies and gentlemen, pleasure for me to be here and to introduce the topic, which is a very important topic, that is use of beta blockers in hypertension. What I will do is to show you the evidence that beta blockers do have a lot of important evidence in favor of cardiovascular protection in hypertensive patients. And they deserve to be included in the major group of antihypertensive agents, something which has not been done by some guidelines. In my opinion, this is a mistake because, as you will see, the evidence is as strong as that of other drugs. These are my disclosures. Now, when the guidelines of the European Society of Hypertension were prepared, 5 criteria were used to decide which should be the major antihypertensive drugs. The first criterion is ability to lower an elevated blood pressure, of course. This is data from a huge database, 40,000 people, and you see the ability of thiazide, beta blockers, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers to reduce systolic and diastolic blood pressure. And it is clear that as the dose is increased, there is a progressive reduction in the elevated blood pressure, and more or less the effect is similar for the 5 drug classes. Now, this is not a minor point because the greatest proportion of cardiovascular protection by antihypertensive treatment is due to blood pressure lowering per se, regardless how it is obtained. So this is a fundamental point, of course. Second criterion, evidence of cardiovascular protection in placebo-controlled trials, when blood pressure is reduced compared to a placebo group. And here you have the evidence for the 5 drug classes I mentioned: beta blockers, diuretic, ACE inhibitors, angiotensin receptor blockers, and calcium channel blockers. And you see that when blood pressure was reduced, this is a meta-analysis of available trials, there was evidence of reduction of cardiovascular outcomes for all 5 drug classes, including beta blockers, as you can see. Third criterion was the same thing, evidence from blood pressure lowering placebo-controlled trials. This time, the ability to reduce the risk of major cardiovascular events related to hypertension, heart failure, coronary disease, and stroke. Here you have data from 2 very large meta-analyses. One was published in 2009, the other one in 2015. And you can see that for all 5 drug classes, patients treated had a reduction in heart failure, coronary disease, and stroke. In both meta-analyses. We're talking about meta-analysis of a large number of trials for something like between 300,000 and 400,000 patients. For beta blockers, this is obviously true, and it is true also for stroke, which is something which is said that beta blockers do not protect against stroke. Well, you can see that in placebo-controlled trial, protection was there, more or less of a similar degree as the other drugs. Now, lately, a more recent meta-analysis of randomized trials was done, beta blockers against other drugs. And you can see more or less the same data. In the group in patients in which blood pressure was reduced by using beta blockers, there was a major reduction in heart failure, more than 50%, major protection, but also a reduction in the risk of stroke. It was a reduction of 23%, more or less of the same order of magnitude as that of other drugs. Then there was a fourth criterion, and this was comparison trials. Trials in which the purpose was not to reduce blood pressure, but to see whether for a similar reduction in blood pressure, one drug class was better than another. Here you have data from meta-analysis published in 2015, and you see that there is no difference between different drugs. For a similar reduction in blood pressure, which you can see here, there was a non-significant difference in the risk of cardiovascular outcomes or cardiovascular mortality. Once again, if you think, this is another evidence that what really matters is blood pressure reduction in hypertensive patients. And this is the latest meta-analysis, the largest one, the most precise one in a way, because patients are divided into primary prevention and secondary prevention, those with the previous cardiovascular events. It has been published recently. One drug class versus all others. And once again, you can see that both in primary prevention and secondary prevention, there was no evidence of a difference between different drug classes. For a similar reduction in blood pressure, as you can see in this column. So for this reason, what the 2023 guidelines of the European Society of Hypertension have done has been to recommend use of 5 major drug classes: diuretics, both thiazide and thiazide-like diuretics. There is no evidence of a different degree of protection between these two subtypes of diuretics. ACE inhibitors, angiotensin receptor blockers, calcium channel blockers, but also beta blockers, because based on the evidence I showed you, there is absolutely no reason for excluding this class from the group of major antihypertensive drugs. Now, today, most meta-analyses recommend combination treatment in the vast majority of the hypertensive population. Only small groups, for cautionary reasons, are exempted from this. But in the majority of people with an elevated blood pressure, we should start with 2 drugs. Well, so there is now another criterion to be added, and this is how protective, how effective is a drug when it's given with another drug in combination treatment. Well, you can see the data for beta blockers. There are 5 major trials been in the past, some of them very famous, the HFpEF trial, the MRC trial, the STOP trial. Blood pressure lowering trials versus placebo, in which beta blockers were used in combination with other drugs, as you can see. And please notice that in all these 5 trials, there was evidence of significant reduction in cardiovascular events, including stroke. In one study, stroke was the primary endpoint. and use of beta blockers in combination was associated with 42% reduction in the risk of stroke. And then there are several comparison trials, that is, one drug combined with another versus another type of combination. Here you have two studies, two trials, LIFE and ASCOT, in which beta blockers lost the confrontation in combination treatment. But in yellow you see how many other trials. This was not the case. That is, beta blockers in combination were similarly protective as the other drugs. And indeed, if you look at what is available in the literature in the last 50 years, you can see that there is evidence of a protective effect of beta blockers together with diuretics, together with calcium channel blockers, together with ACE inhibitors. Now, all effective drugs have, unfortunately, some inconveniences. If you have a drug which does not have any inconvenience, most likely it doesn't have any therapeutic effect. Now, inconveniences in beta blockers are listed here. There are some contraindications: peripheral artery disease, obstructive lung disease, less favorable side effect profile, although recent control studies showed that this has been overestimated, higher rate of treatment discontinuation, less effective against subclinical hypertension-mediated organ damage, an increased risk of new onset diabetes. This is something which is very often discussed at meetings. And this is what it is. I mean, this is some inconveniences in the administration of beta blockers. Other drugs have other types of inconveniences. But what the guidelines emphasize, the guidelines of the European Society of Hypertension, is that beta blockers do not constitute a homogeneous class, but show several pharmacological differences, among which beta-1 selectivity and the additional vasodilator effects. And this is what is going to be discussed in this symposium today. That is the evidence of a beta blocker which is both cardioselective and has a clear-cut endothelial-dependent ability to vasodilate resistant vessels. And from the evidence you will see, it seems to be clear that most of the inconveniences of beta blockers have been eliminated by the additional vasodilatation of beta-1 cardioselectivity. And we're quite lucky because in the last 5 or 6 years, several combinations in fixed dose, single pill combination have been developed in which Nebivolol, which is the prototype of a vasodilator, cardioselective beta blockers, has been associated with other drugs. And I'm sure you will find this very profitable to know what is the state of the art for this vasodilator beta blocker in combination treatment in this symposium. Thank you very much for your kind attention.
Thank you, Dr. Mancia, the delegates over here. Good evening. I'll have a very quick talk on hypertensive young patients with sympathetic overdrive, where perhaps the molecule you're talking about today is the most suitable. Take, for example, like this young man of 40 years who is uncontrolled home blood pressure with tachycardic, but not an arrhythmia. He is hypertensive and smoker, occasional drinker. Father and mother both are hypertensive. His BMI is around 22, so actually he's on the thin side. There's nothing much to see in the physical examination, but his pressure is consistently high both in clinic as well as at home, though ECG hasn't shown any changes yet. But his resting blood pressure is 93. Now, as Dr. Mancia just mentioned, he was the main person behind the ESH guideline 23, where established and suggested novel factors for hypertension-related problems is resting heart rate above 80. That has been taken as a risk factor in a hypertensive person, along with other comorbid things which have been listed over here. So if we see in a quick epidemiology that it is of course a lifestyle disorder and a major risk factor for cardiovascular disease with men and women equally representing. In India, the last survey shows around 30% of population, adult population are hypertensive, both in rural and urban areas, both in male and female, around 30%. And we know that sympathetic nervous system actually plays a role, pathological role, in all stages of hypertension-related cardiovascular disease, starting from risk factor initiation like body weight, diabetes, etc., to ultimately to hypertension, to coronary disease and heart failure. Now, why the beta blockers we are talking about here today, as Dr. Mancia has very beautifully and elegantly put, that we need to control the sympathetic nervous system, with the beta blocker is the best agent for that. And if we see that the hyperdynamic circulation, which is so prototyped in a young hypertensive, so there is a paradox. They say that don't give beta blocker in young people, they get demotivated, they have got male sexual dysfunction and so on. At the same time, they are the people who are driven by sympathetic, who are ambitious, who are careerist, whose heart rate is high, and so on. So actually, it is more of a drug for the younger than the elderly people. So if we see that if you control heart rate and if you do not control heart rate, there is a gross difference, and patients who have got basic heart rate above 80 should have beta blocker on board as a first-line antihypertensive therapy. And of course, Dr. Mancia just mentioned about it, that ESH has shifted from 2018 to 2023. In 2018, where beta blocker had 5 specific indications, like heart failure, angina, post-MI, AF, and ladies planning pregnancy. Now, if you see the right box, beta blocker can be used as monotherapy or at any step of combination therapy. So it is, as he showed, it is a class 1 indication now. And if he has already shown this, it is a very effective blood pressure lowering agent, both systolic and diastolic. And from the data, it has already been shown, I just re-emphasize that it is a myth that beta blockers do not reduce cardiovascular outcome or cardiovascular mortality. It's absolutely a myth which has been busted recently with this very elegant presentation last year in the Journal of Hypertension. About 25% significant risk reduction of cardiovascular outcome and cardiovascular mortality for a 10 millimeter mercury reduction, as by other drugs as well. And it is protective effect from BP lowering trial. This has already been adequately explained by him. I won't waste time on that. This heart rate is related to cardiovascular mortality, as I mentioned, both in normotensive people as well as in hypertensive people. And the cutoff, maybe in normotensive it is 70 is ideal, but in hypertensive it could be around 75, 70. So around 80 we take as tachycardic people for hypertension. And there is a benefit Korea trial where Nebivolol has been tried, which showed that both in young people below 50 as well as above 70, it has got a very good once daily dosing, can cause a very good reduction of blood pressure to the tune of around 10 by 5 millimeter mercury. The role of Nebivolol, if you see in the management of hypertensive patient, even in the meta-analysis, you will see, I don't go into the slide, but just see the big diamonds which are really either neutral or in favor of Nebivolol. Now, as we know that Nebivolol is a chimeric compound with L and D, and L part actually releases nitric oxide. So this is the advantage of Nebivolol as opposed to any other beta blocker, or so to say, as opposed to most other antihypertensive agent. Very few antihypertensive agents are nitrate donors, excepting the Nebivolol, and of course nitrate and nicorandil itself. And D-Nebivolol is actually peripheral vasodilator and a beta-1 receptor blocker. And if you see the highest cardioselectivity of Nebivolol even compared to bisoprolol, whereas of course carvedilol is a non-selective blocker. If we see the HOMA, it is also, if you compare with metoprolol, if anything, increases HOMA a bit, though not significantly. But Nebivolol actually reduces HOMA and reduces insulin resistance and actually increases insulin sensitivity. And by the prototype trials of each beta blocker, Senior, Copernicus, Merit, Series, you see that target dose achieved is highest with Nebivolol. 10 milligram Nebivolol is very easily achieved as opposed to 10 milligram bisoprolol or 200 milligram of metoprolol or 50 milligram of carvedilol. There we actually lag behind a bit. So if you see the study-oriented dose achievement, then you will achieve Nebivolol swifter than any other group. So if you see the ESH, as Dr. Mancia just mentioned, that beta blockers do not constitute a homogeneous class but show several pharmacological differences, among which beta 1 selectivity and additional direct vasodilating property are of special interest. Third generation beta blockers such as Nebivolol exhibit an added vasodilatation via increased release of nitric oxide, reported a more favorable side effect profile than other beta blocker, including the fewer adverse effect on sexual function. Evidence of the advantages of this third generation vasodilating beta blocker exceeds by far that of other beta blocker. These are all quotations from ESH Guideline 2023. And I am talking with this not from just because I have been told to talk, but I'm very passionate about beta blocker, and you see over the last 2 years, I was involved in publishing many trials or many reviews on beta blockers from Indian subcontinent. And what we found that Nebivolol, it is our paper in JAPI last year, Nebivolol in young hypertensive cases with or without comorbidities and resting heart rate, 83% people are doing very well with Nebivolol as with high heart rate. And if we see our preference of beta blocker, that is a survey of the physicians, Nebivolol is preferred by 95% of Indian physicians. So that was, I think we are a bit wiser than rest of the world, as always we think we are. And that we proved here. So amongst the Asian countries, China, Indonesia, India, Korea, Singapore and Thailand recommend beta blocker as a first-line antihypertensive agent. Apart from the usual indication, we also give it as a first-line therapy if the heart rate is above 80, and it is very good also in resistant hypertension, and selective beta 1 and vasodilating beta blocker are the preferred ones, as we have mentioned. Vasodilating beta blocker may be a more appropriate therapy as traditional ones. It has got antioxidant and anti-ischemic effects. It's a nitric oxide donation. We know the importance of nitric oxide, and also it improves and maintains the cardiac output, which may be reduced by traditional beta blockers. Apart from ESH, even the ESC, you know that this time ESC has got a bit contradiction to ESH. They have rifted apart a bit. Dr. Mancia is not here, but still I'm saying that 23 ESH guideline was partially negated by 24 ESC guideline. And when they were asked why there is a difference, the lady just said from the stage, we are ESC, we are not ESH. So that was her answer. I was there. I heard myself. But even they say that beta blockers can be added preferentially in circumstances such as in the presence of angina or heart failure after MI or controlling heart rate. It was their old stand. What is new stand now, where they are the cornerstone of therapy in such setting, second generation cardioselective and specifically third generation vasodilating beta blockers are preferred. So here, both ESH and ESC converge. Though ESC said, still, beta blocker is second line, ESH said beta blocker is first line. But they converge on the point, if you choose beta blocker, choose a third generation beta blocker, which is beta 1 selective and vasodilating. Here, both ESH, ESC and ESH are on the same side. So that is very interesting. So we actually asked, there is our paper in JAPI, that ESH guidelines on use of beta blocker. Will new ESH hypertension guideline help gain confidence to use beta blocker? 96% of our responders said yes. We are now more convinced about beta blocker after the ESH 23. It is an Indian data. So if we go back to this 40 years old man, we added Nebivolol because he was tachycardic and his both blood pressure and heart rate were controlled. So I stop over here. Thank you.
Now I would like to invite Dr. T. Govindan Unni to present on the topic hypertensive patient with heart failure with preserved ejection fraction manifesting with hypertension and angina.
Okay, my topic will be about a hypertensive patient with heart failure with preserved ejection fraction manifesting with hypertension and angina. Let me start with heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction, the so-called HFpEF, is becoming an increasingly common cause of exercise intolerance across the world. And our understanding of the pathophysiological mechanisms, diagnosis, treatment, everything has improved as far as HFpEF is concerned. But it remains that a large number of HFpEF remains under-recognized, not only in India but across the world, but more so in developing countries. But the prevalence is definitely increasing as the longevity increases, and in several countries it has already overtaken heart failure with reduced ejection fraction as the most important cause of heart failure. Maybe in India also in a few years, heart failure with preserved ejection fraction will overtake heart failure with reduced ejection fraction. While older age hypertension and coronary artery disease predispose to both heart failure with reduced ejection fraction and HFpEF, obesity, metabolic dysfunction, and physical inactivity appear to specifically predispose to HFpEF. Now we have this universal definition of heart failure with preserved heart failure, which also includes heart failure with preserved ejection fraction. Heart failure, by definition, should have clinical findings, clinical history, symptoms, and signs of heart failure. That is essential. And there should be a structural or functional cardiac abnormality, which in a heart failure with reduced ejection fraction will be a low ejection fraction. But in preserved ejection fraction will be something else like LVH or a dilated left atrium or something like that. And you should have raised natriuretic peptide levels or objective evidence of either pulmonary or systemic congestion. This is the current definition of heart failure across the world. But one problem with heart failure with preserved ejection fraction is that the natriuretic peptide levels are usually not very high in HFpEF compared to HFrEF. And in fact, about 25% of patients with HFpEF, the natriuretic peptide concentrations can be normal. The survival is almost same. Whether you consider HFrEF or HFpEF, the survival is equally poor. Now, diagnosis is very difficult, but there are several scoring systems, of which probably the easiest to remember at the bedside is known as H2FF, where H2, the 2H stands for heavy and hypertension, F, first step, stands for atrial fibrillation, P stands for pulmonary hypertension, E is elder, and the second F stands for filling pressure. Heavy is more than 30 kilogram per square meter of BMI. Hypertension is 2 or more antihypertensive medicine. Atrial fibrillation, of course. Pulmonary artery systolic pressure of more than 35 millimeter. Elderly, more than 60 years. And filling pressure, E by E dash, more than 9. And then you give points. Heavy gets 2 points. Atrial fibrillation gets 3 points. All the others get 1 point. And now if you plot heart failure, hospitalization, or CV death across these risk factors, you can see that as the number of points increase, both heart failure with hospitalization or CV death also increases. Now, comorbidity management in HFpEF is very important because quite a good number of people in heart failure with preserved ejection fraction do not die of heart failure. They die of other causes, which can include coronary artery disease, stroke, even cancers or cor pulmonale, etc. Blood pressure is, in fact, one of the most common comorbidities with HFpEF, and blood pressure has to be controlled in accordance with the clinical practice guidelines. You can select the antihypertensive agent depending on other comorbidities, like if there is renal failure, maybe you have to give RAS blockers. If there is coronary artery disease, you may have to give beta blockers. So it depends on other comorbidities. Similarly, coronary artery disease, which is another important comorbidity in HFpEF, has to be treated according to the guidelines, maybe with beta blockers if the patient has angina, maybe with revascularization if there is significant obstructive coronary artery disease. In this combination of hypertension and heart failure, it is well known that the role of blood pressure in preventing heart failure, the sprint with intensive blood pressure lowering reduce 50% of heart failure. Hypertension is one of the most important identifiable causes of HFpEF, with a prevalence of 60% to 89% in the HFpEF population. And hypertension, the structural and cardiac abnormalities produced by hypertension, which is left ventricular hypertrophy and diastolic dysfunction, are the hallmarks of heart failure with preserved ejection fraction also. The guideline says you bring down the blood pressure to less than 130 millimeters systolic in hypertension and heart failure. Coming to coronary artery disease and heart failure, again it is very common. Epicardial coronary artery disease in about 50% of patients with HFpEF, and microvascular dysfunction in about 3/4 of the patients with HFpEF. Up to 80% of patients with HFpEF are on beta blockers for various reasons, maybe for hypertension, maybe for coronary artery disease, but data show that more than 3/4 of all patients with HFpEF are on beta blockers. Now, this is the guidelines say hypertension, BP less than 130/80. The classical agents are ARNI, ARB, MRA, and diuretics, but of course you can give beta blocker if there is indication for beta blocker, and evaluate for secondary causes when appropriate. Similarly, coronary artery disease doesn't matter, you treat as any other coronary artery disease, beta blockers for angina, aspirin, statins, and of course revascularization if that is required. Now, if you look at the primary endpoint in various HFpEF trials, you can see that SGLT2 inhibitors reduce uniformly the dapagliflozin, empagliflozin, and sotagliflozin. All of them reduce the primary endpoint. Whereas RAS inhibitors do not reduce anything. That is why they get only a class 2B recommendation. MRI, spironolactone did reduce event rate in the American subgroup of the top CAT study. Whereas you have the fine art study where finrenone reduced the primary endpoint. So you have most data with finrenone and gliflozins. But if you look at death from any cause, you can see that none of these drugs actually have reduced death. And the reason is because death is usually due to, at least a good number of death is usually due to other causes, not due to heart failure. And that is why, as I said earlier, treatment of comorbidities become very important. If you look at this 2023 focused update on heart failure with preserved or mildly reduced ejection fraction, dapagliflozin gets a class 1, no doubt about that. Preserved ejection fraction, again, dapagliflozin gets class 1. If you look at heart failure with mildly reduced ejection fraction, while diuretics and dapagliflozin gets class 1 indication, ACE, ARNI, ARB, MRA, and beta blockers, all of them get a class 2B indication. And in preserved ejection fraction, diuretics, gliflozins get class 1. And then you can see that the class 1 indication is treatment of comorbidities. Again, let me repeat, comorbidities are very important in heart failure with preserved ejection fraction. If you look at the hypertension guidelines to go about how to treat hypertension in these patients, you can see that this slide has already been shown several times. Beta blocker can be used at monotherapy or any step of combination therapy. And a huge number of other indications, including thyrotoxicosis, major non-cardiac surgery, a big list of conditions where you should have beta blocker. And on the right side, you can see one very important indication, which is chronic coronary syndrome, especially if the patient is having angina as an anti-ischemic medication. This again is a profiling of heart failure with preserved ejection fraction. And let me again look at the two important comorbidities which I have been talking about. Arterial hypertension, you can see all those drugs are there, including Nebivolol, which is a vasodilator beta blocker. And ischemic heart disease, again, you can see beta blockers come into the picture. Now let me look at the seniors trial, which is the most important trial with Nebivolol, which looked at patients who are above 70 years with heart failure. There was no definition of reduced or preserved. Patients with clinical heart failure. And it definitely showed benefits on a composite outcome of death bar cardiovascular hospitalization. Now, there were approximately a third of patients who had an ejection fraction which was not very bad, about 35%. So what they did was that they had a pre-specified analysis of those less than 35% compared to those with an ejection fraction of more than 35%.
And it was found that the effects of Nebivolol did not vary whether the ejection fraction was less than 35% or more than 35%. This is less than 35% and this is more than 35%, not much different. Now, if you look at the other outcomes, primary outcome and various secondary outcomes, don't get baffled by this graph. All I want to show is look at the ejection fraction. On one side is less than 35, and the other side is more than 35. And now concentrate on this last group, the p-value for interaction between less than 35 to more than 35. And you can see that none of the p-values are significant, which means the benefits are there whether the ejection fraction is less than 35 or more than 35. A more contemporary data on the use of beta blockers in HFpEF comes from the DELIVER trial, which is, is the largest randomized trial with dapagliflozin, LVE of more than 40%, two-thirds having LVE of more than 50%, and as I said, more than 80% were on beta blocker for various reasons. The pre-specified analysis of DELIVER trial looked at the implications of beta blocker in both mildly reduced and preserved ejection fraction. They were on beta blockers for some indication. It is not that they were just put on some indications, and the indications were hypertension, atrial fibrillation, flutter, coronary artery disease, or previous LVEF or more than 40, less than 40. So you can see that a good number, nearly 50% had 2 indications, and about a third had 3 indications, which means that most of these patients with HFpEF have an indication for beta blocker. Beta blocker use was associated with a lower risk of primary composite of worsening heart failure or cardiovascular death. Even though this is a sub-study, it was a pre-specified endpoint which showed the benefit of beta blocker in this group. And the beta blocker benefits was not determined by the ejection fraction, whether it was less than 49 or more than 50%. As you can see here, the beta blocker versus no beta blocker, and look at the p-value, which is very significant, less than 0.001. So to conclude, ladies and gentlemen, beta blockers are in general not indicated for heart failure. If you look at the guidelines, one drug which is not indicated is beta blocker. But most patients, as we have seen, 80% of the patients have reasons to be on beta blocker, various comorbidities. And as I said, comorbidities determine the longevity in heart failure with preserved ejection fraction. And so management of these comorbidities is of utmost importance. Hypertension and CAD are probably the 2 most important comorbidities, and among beta blockers, that is, if you want to give a beta blocker as a treatment for hypertension or as a treatment for coronary artery disease, or maybe for atrial fibrillation flutter to control the heart rate, Nebivolol has some data. None of the other beta blockers have any data. Nebivolol has done some data in the pre-specified subgroup analysis of seniors trial. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Sandip Bansal to speak on the topic hypertensive patient with prediabetes with coronary heart disease.
Good evening. My job over next 10 to 15 minutes is to discuss with you what do we do when a patient has pre-diabetes and for optimal management of hypertension he needs a beta blocker because of presence of coronary artery disease. As the topic is about pre-diabetes, couple of my slides are going to talk about pre-diabetes. To this audience, I need not give the definition of pre-diabetes, but just to remember, it is when the HbA1c is between 5.8 and 6.5, or you have impaired fasting glucose, or you have impaired glucose tolerance test. So significant metabolic, physiological, and biochemical features are dysregulated by the time the patient has pre-diabetes, and several trials have demonstrated that if you are able to stop the development of diabetes, progression of pre-diabetes to diabetes, then it is a great thing that you can do. The India B study recently actually showed that we have about 100 million diabetics, but we have slightly more number of pre-diabetics, and about a third of diabetics are going to become diabetic within the coming 5 years. So in that context, pre-diabetes is extremely important. This is a slide which talks about the, which tells us about the progression of the diabetes. And as we see on the left-hand side corner at the bottom, almost about 10 to 5 years before the diabetes has been diagnosed, the pre-diabetes takes place. And even after the patient becomes diabetic, it is a period of 5 years on an average before the patient becomes to be known as a diabetic. And in these phases, the pre-diabetes and before you're an undetected diabetic, both the macrovascular and the microvascular complications do occur, and this is an extremely important fact to remember. So the important point that this slide tells us is that by the time you are a pre-diabetic, your risk for both macrovascular and microvascular diseases has already started. So this is the point that is being made. Another important point is that we know that there are several factors which contribute to diabetes, and the ones which are being ticked in yellow are the ones which are also responsible for pre-diabetes. So important point to remember that the factors which ultimately lead to diabetes are also present in pre-diabetes. At least the vast majority of those factors are present in pre-diabetes. And as far as the cardiovascular disease in diabetics is concerned, it can be with hypertension or without hypertension, and it's a two-way relation. Diabetes gets hypertension and hypertensives get diabetes. So it is a two-way relation, and because of associated atherosclerosis and endothelial dysfunction, inflammation, vascular fibrosis and remodeling, the micro and macrovascular complications take place, as I showed earlier. Now, what do the guidelines tell us? They tell us that the patients who have diabetes and high blood pressure have they have a much higher risk of developing cardiovascular complications, and we should risk stratify these patients according to the patients or according to the presence of diabetes and hypertension. Now, this is an important paper. It is not a very large study, about 400 patient study, which actually looked into the severity of the presence and severity of coronary artery disease in those patients who were non-diabetic versus pre-diabetic versus diabetic. So the two major, conclusions from the study were that as far as the number of vessels, the involvement of left main is concerned, it was more in the pre-diabetic patients as compared to the normoglycemic group. But when you compared pre-diabetes with diabetes, it was not a statistically significant difference. Gensini score is one of the methods that we give to our students to diagnose the severity of coronary artery disease. And here again, pre-diabetic patients had a higher score as compared to normoglycemics, but no significant difference with the diabetic population. Again, this is another important slide which shows us that in the pre-diabetic group, which is highlighted in the yellow, the cardiovascular insults, peripheral arterial disease, and acute myocardial infarction, that is coronary artery disease, is already elevated. So coming to a case, this is a case of a guy called Rajesh who has uncontrolled home blood pressure, and he has angina of effort with CCS2 symptoms. For his hypertension, he is on a sartan and amlodipine, which is a very popular combination. For his pre-diabetes, which is based on oral glucose tolerance test and a HbA1c of 6.1, he underwent a treadmill test wherein he had a 1 millimeter ST depression in stage 3, but his exercise time was good, about 10 minutes. So he did not undergo a conventional angiography, but he underwent a coronary CT, which actually showed that there was a disease in the circumflex and the right coronary artery in the middle and distal portions. Therefore, he was decided to be put on medical treatment. He has two healthy children. His father is 84 and his mother is 82, and both are in good health. He doesn't have tobacco usage, but he takes some amount of alcohol. His BMI is below 25. His cardiac and carotid auscultations, etc., reveal nothing very different. The lower limbs are normal, but the patient has raised blood pressure, as is indicated here. He also has, a heart rate which is 96 beats per minute. Another important thing is the ankle brachial index of 0.9, which is suggestive of a mild peripheral arterial disease. So he does have that peripheral arterial disease. So coming to our discussion of beta blockers, we are aware of the first, second, and the third generation beta blockers. The third generation being the ones which have peripheral vasodilatory action. They are again divided into two, those which are beta-1 selective and those which are not. Now, in terms of the effect of beta blockers on the glucose homeostasis, as we see here, the change in glucose as induced by nebivolol and metoprolol is almost similar, but the insulin sensitivity, the point that my friend Dr. Saumitra Ray also highlighted, the insulin sensitivity and the HOMA index, they are significantly less in case of nebivolol. So again, this is another study to show that as compared to metoprolol, nebivolol is much better in reducing the insulin resistance in patients who are diabetics as also who are pre-diabetic. This is from the 2018 ESC, ESH guidelines. These actually showed that there is a beneficial effect of nebivolol in terms of side effects particularly. For example, like the erectile dysfunction, another point that has already been made. This is another point, actually this is a repetition of what Saumitra said, that almost 95% of the Indian physicians were satisfied with nebivolol as compared to, which is more than any other beta blocker that was used. There have been studies in which nebivolol has been studied in hypertensive patients with diabetes. There are no specific studies in pre-diabetic group in particular, but in diabetes, there is this Yestono study which says that strongest reduction in blood pressure in patients with type 2 diabetes can be achieved with this cardioselective beta blocker nebivolol, typically used in a 5 milligrams dose, and particularly when added to other groups of antihypertensive agents. And the nebivolol shows improvement in glycemic and lipid parameters. Similarly, there are other studies like this one, which is a post-marketing surveillance, again showing similar benefits, and there are other data to show that there is a certain amount of reduction in microalbuminuria in patients who have diabetes but are put on nebivolol, a beneficial effect, which is not seen by other beta blockers. So this again has been shown that this slide talks of the ESC guidelines. It also talks of the fact that beta blockers like nebivolol, which have beta-1 selectivity and nitrate oxide mediated vasodilatation, are an important and useful tool in the management of patients who have hypertension, diabetes, and associated coronary artery disease. Our patient in particular was a very fertile ground for using nebivolol because he also had peripheral arterial disease where you should not actually use the other beta blockers. So as far as the recommendations are concerned, Nebivolol is not associated with worsening of glycemia, increased glycemia, and there are no increases in the complications related to diabetes, and in fact, as I showed, that the glycemic control and microalbuminuria are reduced if we use Nebivolol as a drug in patients who need beta blockers. So our patient who had uncontrolled high blood pressure, who had angina of effort, he's added Nebivolol 2.5 milligrams a day. For his pre-diabetes, although for pre-diabetes there's no definitive treatment that has been defined, some people have used metoprolol, but this patient was started on canagliflozin because he has associated coronary artery disease, and this patient improved on a 6 months follow-up. His glycated hemoglobin came down to 5.1, the blood pressure got controlled, and so did the heart rate. I thank you for your kind attention.
Thank you, sir. Now I would like to invite Dr. B.K. Sahoo for the next session to speak on the topic, need for a beta blocker in COPD with hypertension.
Good evening, everybody. In fact, if you are asked to, if you write a beta blocker for a COPD patient, first your chest physician will first cut it out. He'll tell that the problem with you is that because you are taking a beta blocker, now all these issues have started. You're taking an inhaler, you're taking all these things. So let me try to rest my point on how to treat a patient of hypertensive with COPD. We know these are the various selective beta blockers that are available, and these have already been covered by my previous speakers. Now, the question comes, a very simple question: which beta blocker should I choose in a patient of COPD with hypertension? A simple question. We know all about beta blockers, we've been speaking since ages, and now we want to know it is whether this beta blockers in COPD is a controversy which has been resolved. It has been shown, this was an article from 2019, where it shows that systemic reviews have recognized the underuse of beta blockers in patients with COPD who have coexisting cardiovascular disease because of fear of worsening heart failure. So this is lung function. So this is a very important aspect which was discussed. And then came an editorial that beta blockers in COPD, the show must go on. Because it is not that in COPD patients that we should stop beta blockers. And then which beta blocker already has been shown by my previous speakers that definitely it should be Nebivolol. But this is a drug which has been almost a decade long in our country. But why are we giving so much importance today? Why are we thinking about it? Because possibly the US did not accept it much. It was a drug from the Southeast Asia or the Japanese countries, where that is why much of importance was not given. Now, if you see the association beta blockers with survival and pulmonary function in patients with chronic pulmonary disease, the systemic review clearly shows that if you give beta blockers in COPD patients, it really does well. Now, the clinical significance of the selective beta-1 blocker is that bronchospasm may be accessory of beta-2 receptor agonist. Non-selective beta-1 blocker should not be used, and the recent study shows that if you use a beta-1 selective drugs, definitely it is not contraindicated in severe asthma. Now, why? Because if the beta-1 selectivity is high, efficacy is better for the heart, bronchospasm is less, and as Professor Bansal had said, the metabolic and other side effects are also less. So low beta-1 selectivity means increased metabolic and respiratory side effect. Now, certainty is fading away. That is, beta blockers do not worsen COPD. This has to go because they are not dangerous, especially if we use selective beta-1 drugs with low doses. And the best thing is to start with Nebivolol or other low-dose selective beta-1 drugs. Now, Nebivolol, a full review clearly stated in the JACC that Nebivolol has the greatest specificity of beta-1 receptors, which explains its highest tolerability in patients with lung disease. So this is a drug among the beta blockers which should be selected, and we know that as Dr. Saumitra Ray had said about adrenergic drive, we are in adrenergic India where you see the sympathetic drive is more. And this has been published in Indian Heart Journal and has showed that almost 62.42% of our patients have a high sympathetic drive. And definitely the drug to get it down is beta blocker, and among the beta blocker, it would be best to use a beta 1 selective blocker. Now, I did not go through all these things because it has already been highlighted, it's safe and effective, and definitely the Swedish COPD versus non-COPD patients showed that the relative risk was higher for heart failure, CHT, and stroke, and most commonly attributed was arterial hypertension. So there is a good evidence that we have that we can use this Nebivolol in these patients. The 2023 ESS guidelines clearly states hypertension and CVD should be treated, if tolerated, with more beta 1 selective beta blockers to reduce both mortality and COPD exacerbations. Now, this was the paper which has been quoted by all my previous speakers, that this is a recommended beta blocker for as per the Indian consensus. And if you see, the hypertension with COPD requiring a beta blocker, which is mild asthma, it is moderate asthma, COPD stage 1 or COPD stage 2, in all these groups, beta blockers do well. And if you give a 2-week therapy also, compared with nifedipine, it has been shown that it is better. Now, Nebivolol does score, and that is why it has been shown that it is rational, and it is extremely prudent to choose Nebivolol in these patients of COPD. Now, this has also been shown by one of my previous speakers that Nebivolol is the only drug among all the beta blockers which has got the best role in controlling hypertension in the COPD patients when you compare with the placebo. So, can a patient with COPD or asthma take a beta blocker? Yes. Cardioselective beta blockers, that is those which block predominantly the beta 1 receptors, are our beta blockers of choice based on stronger evidence from clinical studies. There is enough evidence. So next time your pulmonologist cuts it, please be careful that they also should know that this is the safest drug. So as has been said by Quicksang, beta blockers have been since long, but still then it continues to surprise us. New evidence is coming. Over the decade, we have been seeing that definitely Nebivolol is something which is a drug for the future, and especially for COPD, there have been various studies which have shown that this is the drug that is to be used. Thank you, ladies and gentlemen, for the patient hearing.
Thank you, sir. Now we move on to our panel discussion and question and answer session moderated by Dr. Govindan Unni.
We already had a very extensive discussion on various topics, role of beta blockers. So I'm really not sure what more to have in this panel discussion. But anyhow, when I was a medical student, when I was asked what were the contraindications for beta blockers, the three important contraindications, heart failure, bronchial asthma, and bradycardia were the three important contraindications. And when I was asked about the indications for beta blocker, hypertension was on top, because those days only beta blocker and diuretics were there. The stepped care approach, you start with beta blocker, add a diuretic, or the other way around. Those were the only two drugs. Now as time passed, beta blocker is now the #1 indication for heart failure, at least with reduced ejection fraction. And hypertension is, if you look at the guidelines, beta blockers comes low in the list as far as hypertension is concerned. So things have changed. Basically, if you compare other drugs with beta blocker, there is not much difference between losartan and say olmesartan, except maybe the duration of action or some minor differences. Whereas propranolol and nebivolol are two different drugs. I don't think you can compare propranolol and nebivolol even though they belong to the same group. So that is the difference that we have. Let me start with hypertension, because after all, that is the most important thing. Dr. Saumitra has already told us why beta blockers should be one among the first-line drugs for hypertension. But in your practice, in which patient do you really start? I mean, if there are no other contraindications, a garden variety patient coming to you, what would be your role of beta blocker?
As I mentioned, if you ask me personally, I start beta blocker very frequently. It's one of my favorite drugs, and I give almost to all patients unless contraindicated. But if you go by the guidelines, then you choose those patients who apparently in your chamber, in your clinic, is sympathetically overdriven, who are tense, who are sweating, who has got tremor, who is talking very voluminously, who shows the symptoms of generalized anxiety disorders. And if you feel the pulse is high, resting pulse is above 80, these are the features. Also, I take into consideration if there is family history of premature coronary disease or sudden cardiac death. So in this group of patients also I prefer beta blocker, because beta blocker is one of the most important drug which has been proved to prevent sudden cardiac death. So in this group also I prefer beta blocker. Apart from that, there are usual indications of ischemic heart disease, heart failure, arrhythmia, ladies wanting to be pregnant and so on. So these are the standard thing. But I think it's very important, and we know that there was survey that Indians are generally high renin hypertensive or low renin hypertensive. In every society there is a division. In India it has been shown by various anecdotal studies that 2/3 patients are high renin hypertensive. And that is also supported by the fact that Indian hypertensives are more or less they are metabolic syndrome patients. They are overweight or obese, they have got dysglycemia. So these group go hand in hand with high renin hypertension. So high renin hypertension usually is treated more by RAS inhibition and beta blocker rather than by calcium blocker and diuretic. They actually stimulate RAS. So I think majority of Indian profile patient require beta blocker and RAS inhibition. What is unfortunate, Dr. Unni, as you mentioned, have you ever thought that when you say the antihypertensive, do we say RAS blocker? We say ACE inhibitor ARB. We clearly divide and we categorize. When we say calcium channel blocker, do we put diltiazem and amlodipine in same category? We say DHP, non-DHP. So why in beta blocker, we still do, it is not our habit or use or even in guideline to say beta 1 selective and beta 1 and non-selective beta blocker. Why do they clump? Even in 2025, beta blocker is the only group which is clumped. Calcium blocker is not clumped, RAS blocker is not clumped. So why beta blocker is clumped? It is totally unscientific. We must divide the beta blocker, just like RAS blocker and calcium blocker, and then the picture will change.
Yeah, thank you, Dr. Saumitra. As you said, these patients, unfortunately, the patients who are anxious, tremulousness, are all young patients. Our target-driven patients, whether they are in the IT sector or even our pharma friends who have their targets every month. These are the young patients. And unfortunately, whichever trial with beta blockers across the world, if you look at the exclusion criteria or inclusion criteria, you will see above 55 years or above 60 years. So these type of patients are not included in any of the trials. And the older the patient, the less their renin and sympathetic activity, they don't respond to beta blockers. But the problem with the older beta blockers, as Dr. Saumitra said, if you give in a young patient, they have all problems. Erectile dysfunction, fatigue, inertia. So what we require is a very specific beta blocker, like probably in that situation, Nebivolol is the best drug. Now coming to the second aspect, they are all absolute contraindication in olden days. In olden days, when you were asked about the relative contraindications, the two most important were diabetic and peripheral vascular disease. We were told that don't give diabetes in beta blockers and diabetes or peripheral vascular disease. Dr. Bansal has already talked about diabetes, but let me again ask him the same question. In which diabetic hypertensive would you really choose a beta blocker other than a RAS blocker?
See, the index patient given to me had coronary artery disease and peripheral arterial disease. So for coronary artery disease, you need to give a beta blocker, and if he has associated peripheral arterial disease, we need to give them a beta blocker with a vasodilatory property. So that is one group of diabetic patients wherein I would use. The others are, of course, the common garden variety. As Saumitra said, I entirely agree with the 2023 ESC, ESH guidelines, which said that if the heart rates are more than 80, they are another category of patients. And the third thing is when there is this problem of using beta blocker as a first line or not as a first line, Dr. Mancia said that, Saumitra reiterated again the same thing, that the thin line of whether to use it as a first line has been dimming. The second thing is, in most of the diabetic hypertensives, we will not use it as the only drug. So perhaps in every single patient who's a diabetic hypertensive and has some bit of tachycardia, you can use it because you're already using a background RAS inhibitor mostly, or a RAS with a chlorthalidone. So practically there will be a very large percentage of people who will have diabetes, yet they will be able to tolerate the beta blockers. The only thing that we were taught in our younger days is that we should be aware that they can mask the symptoms like tachycardia, and we were also taught that the sweating still takes place if the patient has hyperglycemia or hypoglycemia, as the case may be. That is not masked by the beta blockade. So that is one of the reasons why and another realization has been that the diabetics tend to benefit more from the therapy than the non-diabetic population. So that fear or the relative contraindication that you said is, which was diabetes, has been going away. The fear about peripheral arterial disease, the fear used to be because the beta-2 receptors which are in the periphery, if they get blocked, they cause peripheral vasoconstriction. Nebivolol has beta-1 specificity, which is the highest. So something like several thousand, about 1,500 beta-1 receptors will be blocked, only then one beta-2 receptor would be blocked. So they are extremely beta-1 selective, and in addition they are vasodilatory. So that peripheral arterial disease contraindication also gets knocked off.
Okay, please.
Most of the diabetes patients have non-dippers. I am Arvind from Jaipur.
Beta blockers effect on dipping, specific effect of beta blocker on dipping, I'm not aware of any major paper. But in general, antihypertensive therapy, the best drugs to affect dipping are calcium channel blockers. That is a well-known fact. Beyond that, almost all drugs are equal, and there are not very many large studies which would specifically look at I can't recall a specific study which says that beta blockers affect or they benefit or they don't benefit dipping. I'm not aware of.
So it is what you told, it is 2 or 3 drugs most of the time we need for diabetic hypertension.
Yes. That's the
single drug usually doesn't work.
Doesn't work and is not used. Practically, if we count our 100 previous diabetic patients, I'm sure none of us would recall an instance where we have used beta blocker as a single drug, as an antihypertensive.
The relative contraindication for the diabetic hypertension, again, the person who has a labile sort of diabetes or the recurrent hypoglycemia. I think so we should be very careful.
I did highlight that point, that we were told that, we can miss out because the tachycardia would be blocked, but the sweating does not get blocked out.
Thank you.
I think the one important point which should be emphasized is that in diabetes, when there is an indication for beta blocker, like heart failure or post-myocardial infarction, the benefits in diabetes are actually more because the absolute benefit is more. So naturally, the absolute number of events prevented or number of deaths prevented actually is more in diabetic. That is one point which I think we have to be very clear about. And finally, coming to COPD, the most important thing is that COPD and bronchial asthma are different. There is no contraindication for beta blocker in COPD. It is only in reversible asthma that there is a contraindication for beta blocker. Again, let me ask you, COPD with hypertension, what will be your approach?
COPD with hypertension, we have to see if there are any coexisting conditions.
Now, if there is hypertension with COPD, these patients basically have a higher sympathetic drive. So naturally their heart rate is always high, so it is better to always go for a beta blocker. Now, we do not use beta blocker in isolation again in these patients. We definitely add a sartan or we add some other drug, supposing they have right heart failure or anything. So we have to add something so that we can take care of this thing that is heart failure symptoms also. But given a choice among the beta blockers, definitely to beta 1 selective beta blocker, and with the highest beta 1 selectivity, it is definitely Nebivolol.
COPD and coronary artery disease have a lot of risk factors in common. So it is not uncommon that they come together. Most of the time, these two diseases go together.
I just wanted to talk about COPD. So many a times we have most of the clinicians, they are not able to clearly distinguish COPD with asthma. And most of the patients of COPD will have some amount of reversibility also. So we should be cautious about that, number one. And number two, as for the diabetics or COPD, the Indian hypertensives, they've been shown that they have a sympathetic overdrive. So beta blockers, they can be handy. They are, in fact, Dr. Saumitra was saying that he is using it very often. So that's very rightly said. But we should be cautious in both these situations.
What applies to diabetics applies to COPD also. COPD with heart failure, for example. Beta blockers are definitely useful. If you withdraw beta blockers, it may land up in problem. So like diabetes, because the absolute risk is higher, naturally the absolute benefit also will be higher, will be give a beta blocker. We will throw open the discussion to the audience. Any questions, comments, anywhere is welcome.
Yes, sir. Sir, regarding hypertension and diabetes, we usually need 2 or 3 antihypertensive agents. And you are telling that there are nocturnal non-dippers, especially in the diabetic. So do we need to divide in the morning and evening these antihypertensive so that the early morning chances of the stroke or related comorbidity should get reduced?
Yeah, so this is a question which is asked in every hypertension meeting, whether what is the best way. There was a time when there was a 203 patient study which actually showed a reduction in mortality if the drugs were given in the evening. But when larger studies were done, it was seen that that was probably effect of a small size study and no mortality reduction takes place if you give the drugs exclusively in the evening. The current understanding is that when you are giving antihypertensive treatment, by and large, 2/3 of the dose should be given in the morning and 1/3 should be given in the evening to prevent the morning surge. That is the short answer.
May I just add on this that in the days of combination therapy, we have to be careful what we are combining. Because many times I have seen that in 2 or 3 combination, you are giving the longest acting drug from one group and a short acting drug from another group. And then you are defeating the purpose. And this morning dip is one of the problem when you are not giving long acting drugs. So if you combine Nebivolol with amlodipine, it's a fantastic coverage for 36 hours. But if you combine Nebivolol with cilnidipine, then you are covering for 12 hours. So you are defeating the whole purpose of the combination. So when you are adding, say, a losartan with amlodipine, again you are defeating the purpose. So if you give losartan and cilnidipine combination, give twice daily, fantastic. Or telmisartan amlodipine once daily, fantastic. So you have to be a bit rational about the PK/PD, what you are doing. Otherwise, you will have these non-dippers and reverse dippers because you are not covering the last 6 hours. And of course, as I said that usually it is practiced to give once daily, whether it is at night or morning, it does not matter at all. Whenever you suiting your lifestyle, you give it once fixed dose. But if your HBPM or ABPM shows any particular time of the day while it is not covered and the pressure is not getting controlled, it may be in the afternoon, it may be in the early morning, it may be in the midnight, then you have to specifically cover that period by giving an extra dose or something. But it has to be individualized.
So what is most important is not the time. What is important is the duration of the drug. Select a drug which is long-acting. Beta blockers, the longest-acting are Nebivolol and bisoprolol. You can give once daily. If you give away ACEI, perindopril, lisinopril are all real long-acting drugs. Telmisartan is another long-acting drug. So better give a long-acting drug, whatever the time. Any other comments and from the audience?
Sir, regarding non-dipping of this blood pressure, any specific choice of the antihypertensives in nocturnal non-dippers? Any specific drug of choice among these ACE-ARB, CCBs?
We talked about that. CCBs are the best. Amlodipine is the best drug.
Most of the time, the one thing to exclude is that the patient is having an OSA. Because one of the commonest causes of nocturnal hypertension is when the patient is having, or not only OSA, any sleeping disorder. And maybe treatment of the sleep disorder may help more than any drug. If there are no more questions, I think we'll conclude this session. We had a very interesting long session. Thank you very much. And thanks Torrent also for sponsoring this session.
Thank you, sir.